Yeah, can you all hear and read me?
Yes.
Perfect.
Yes. Perfect.
So what are the refractive surgical options post-phakic IOL implantation? And Toby already mentioned the type of lenses that we are confronted with as a refractive surgeon, as well as a cataract surgeon, as they are the anterior chamber lenses, the Artisan and the Artiflex still on the market, but the Cachet out of the market. But still, we are confronted with the Cachet because many eyes received this nice lens, but not anymore. Then we have the posterior chamber phakic IOL, of which the Evo-Visian is the most successful, and new on the market is the IPCL, the diffractive IPCL as well. So the ways to encounter these refractive surgical options after implantation, they are very much depending on what type of IOL have been implanted. Now, what would be the indications for a post pIOL surgical intervention? First of all, of course, there's residual refractive error, which can be addressed with laser vision correction, as we heard. In the 20 years that I've been, or 25 years almost, that I've been implanting phakic IOLs, I've never had to exchange a phakic IOL because of progression of myopia, which is remarkable. The option usually that we have to consider is laser vision correction or astigmatic keratotomy, as we learned from Tim. So progression of ametropia could be something we are facing. But in my experience, once a highly myopic patient develops a progression of myopia, for example, he will be in an age where he benefit from a little of myopia because they turn out to become presbyopic. So it's not so much of a problem, really. Whereby the onset of presbyopia in these eyes, when they are ametropic, really gives you a headache because you don't know really what to do. You know that sooner or later they will develop a cataract when they are maybe 50, 55 or 60, and you are kind of reluctant to do laser vision correction monovision on these eyes. So this is a problem sometimes where you try to gain some time in order to find a good solution. And the most prominent and most frequent cause for surgical intervention post-pIOL is a reduction of best corrected visual acuity. And what is the reason? The reason is cataract. So what are the causes of cataract in these patients? In the anterior chamber IOL, mostly it's a multifactorial composition of age, myopia, and also iridectomy on its own has been discussed. And what we usually see is a nuclear sclerosis in these eyes. And it's kind of age-related development, but myopia and iridectomy put something on it. With the posterior chamber IOL, we see the same situation with age and myopia. And before the times of the Aquaflow Visian ICL, we had to do iridectomies as well. So iridectomy could also play a role in the development of cataract. And of course, the relative position of the implant with regard to the vaulting and the contact to some adjacent tissue, as we can see here on the picture down below the slit lamp photo. And typically, these patients show up with the anterior subcapsular opacity. So we followed up the ICLs that we have implanted, and we can retrospectively now look back to more than 20 years, and we checked 504 eyes, and the rate of cataract formation was about 7%, of which half of the eyes was subcapsular and half of the eyes were nuclear cataracts. The mean age, and this is now the interesting point, the mean age of the patients or the eyes that developed cataract was at time of implantation 41 years. The mean age at surgery was 49 years. And if you compare this to the mean age of the implantation of the general population of our ICL patients, then the cataract patients are 10 years older. The mean age of our total population of ICL implantation is in the range of 33 to 35 years. So the mean carriage time of the ICL after implantation in these patients that developed cataract was 9 years, between 1 year and 20 years. Another important aspect in these eyes is that the majority of these eyes that develop a cataract is highly myopic, more than minus 7.5 diopters. So we see that an older age at implantation and a high myopia gives us a higher risk to develop cataract earlier than it would develop normally. Now, a refractive surgical patient with a cataract remains a refractive surgical patient with high expectations regarding the refractive outcome. And therefore, I still consider this kind of procedure a refractive procedure. It's a refractive cataract procedure that we have to perform. Now, if you look at the anterior chamber lens, what would be the best strategy to do the surgery? I mean, the patient expects a one-step procedure. You would not want to do it in 2 steps. You would want to do it in 1 step. And the solution that has been proposed here, I think on the first glimpse, it looks nice, but I don't think that it's really a good way to do it, because it, of course, gives stress to the tissue of the iris. And secondly, you have to enlarge the PLI or the CCI up to 5 millimeter to explant the lens, and then you have to suture it, and that gives you astigmatism. I think there's a better way to deal with the explantation and the cataract surgery of a anterior phakic IOL, and I want to share this short video with you. It's about, I think that the main idea is about that you have to change position and that you have to create a good and self-sealing tunnel. You should just go as far into the conjunctival area that you do not have to suture the conjunctiva, and you make the tunnel of 5 millimeter. And then the next step is to de-enclave the lens. Of course, you can nicely do it with the same instrument that you use for enclavation, but not every cataract surgeon does have this kind of instrumentation. So it's also very easy to do with a push-pull hook and a Sinski hook. You just easily excavate the lens. And this is now an Artiflex lens. Here the artisan lens, and then the explantation here over a 5 millimeter tunnel that is almost self-sealing. And you grab it with a crocodile and take it out. And this is now, this suture is a single cross suture where the knot is buried, and you should not make it too tight because you will create astigmatism. You should just adapt the wound lips. The wound lips. Implantation and phakoemulsification can be easily done then when you switch the position from 12 o'clock to the temporal side, and you do a normal phakoemulsification without any problems. And the suture at 12 o'clock is almost astigmatism neutral. So the main challenge in phakic IOL eyes developing cataract we have to face is high emmetropia. And otherwise, the procedure is done as a normal phakoemulsification with peribulbar anesthesia, a perilimbal incision of 2.5 millimeter, which is a little bit larger than the used 2.2 millimeter. So you have to bring up the bottle a little bit in order to make sure that the pressure in the anterior chamber is safe. As you can see here, femtosecond laser does not work very nice because the gas is captured, and the laser doesn't work very nice in these eyes. So usually I don't use it for this kind of surgery. Now, with the explantation of the ICL, I do use the same size of incision that I do use for implantation is 2.5 millimeter. It's a perilimbal or clear cornea incision, and the explantation is actually as easy as the implantation. You lift the two of the haptics or the haptic plate in such a way that you, again, with the crocodile forceps, you can explant the lens nicely through this 2.5 millimeter wound, which is later used for the normal phakoemulsification procedure. So the lens is explanted, and you continue with the rhexis. In these high myopic eyes, I usually do a larger capsulorhexis, and the reason is mainly that the lenses that are available in the range of +5 to -5 diopters for the high myop eyes, they are usually always hydrophilic lenses. I don't like these hydrophilic lenses very much because they can cause capsular fibrosis, and this is the reason why I do a very large capsulorhexis. I try to prevent wound healing in terms of capsular fibrosis. So in this case, posterior chamber lens is implanted. You see it's a hydrophilic lens, and it's implanted just under irrigation. And in the next step, the anterior chamber, as you will see in a moment, is filled with viscoelastics. And a multifocal add-on is placed on top of the posterior chamber lens. And that is, of course, the presbyopia solution in this individual. So the main trick here to do a normal phakoemulsification through a 2.5 millimeter incision with a 2.2 millimeter phaco tip is to lift the bottle. Or if you are using the Centurion phaco machine, then this process is automated and the anterior chamber pressure is maintained through the sensor of the phaco tip. So this is about the procedure. If you look at the refraction post-phaco, and in this chart we have 32 eyes after explantation of the Phakic IOL. You see that 85% are within plus minus 1 diopter. And please note that the range of refraction before Phakic IOL implantation was from +5 to -20 diopters. So highly myopic patients usually tolerate monovision perfectly well in my experience. And that's what I usually try to do because otherwise you sometimes have to do an additional surgery, a LASIK touch-up. And here you see the time course nicely of these eyes. Here are 43 eyes. The spherical equivalent before the ICL implantation was -9.5 up to -24 diopters. Mean uncorrected visual acuity post-ICL, uncorrected visual acuity 0.8. Before cataract surgery, it drops down to 0.4. Spherical equivalent before cataract surgery and after cataract surgery, it even improves. And mean uncorrected visual acuity post-cataract surgery was 0.6. With the laser touch up to 0.6, best corrected visual acuity 1.0. So complications, you see the same kind of problems that you see with normal cataract surgery, but not really severe problems. And overall, the improvement of uncorrected visual acuity and past corrected visual acuity was secured in 100% of the cases. Not one eye lost a line of uncorrected or best corrected visual acuity after cataract surgery post to this procedure. So in summary, the most common reason for surgical intervention post pIOL implantation is cataract. The risk to develop a cataract is age beyond 40 years at a time of ICL implantation in combination with a high myopia. The cataract procedure post-ICL implantation is a one-step procedure and needs special attention because of the higher metropia. And this is also very important. The expectations of our patients, they are very high. They are especially very high with regard to the refractive outcome. They are refractive patients still. Presbyopia can usually and easily be addressed with monovision, but of course you can also implant premium IOL, EDOF IOL, or trifocal IOL. But you put yourself under pressure because if you don't hit target refraction, you have to do a LASIK touch-up. And that's why I usually prefer to do a monovision in these patients. So the point of discussion I would like to mention here, and thank you to Toby, I listened to your presentation before, is how do we position the new presbyopia correcting posterior chamber phakic IOL, knowing that we do implant these lenses on eyes older than 40, 45 years. And what are we going to tell the patients? I mean, the risk that they will develop the cataract earlier than usually, it's just imminent. And in what I think about this situation is that with the presbyopic ICL, we have a transition phase, like in terms that we do not want to do reflective lens exchange too early. And with the presbyopic phakic IOL, we might gain another 5 or 10 years. Once the patient is 55 or 60 years old, we feel much better to do a cataract surgery or refractive lens exchange on these patients. So this would be my last thesis or comment. And I'd like to thank you very much for the kind invitation. And yeah, let's discuss this.